It's okay.
All
I think Sonia started it. She just did her.
Okay. So I am really delighted on this Friday to have Rob Steiner, my colleague, an esteemed professional and academic working in the field of health communications. Rob has agreed to do these rounds on a very hot topic, and he's got some original ideas that I haven't heard yet. So I'm looking forward to hearing them. Generally, the format is that we have one speaker who speaks for up to 35 minutes, give or take. Then we have two discussants, a faculty discussant and a trainee discussant. Unfortunately, our step-in faculty discussants at the last moment, just about 10 minutes before this event, emailed that they are unwell today and can't be joining us. So we're going to make do with just one, but a great discussant we have today. We have Archmond, who's a PhD student. I'm going to introduce Rob, and then I'm going to introduce Archon, and then we're going to get off to the races. So Rob Steiner is the founding director of the Dell Atlanta Fellowship in Global Journalism. This is the only program of its kind, mentoring subject matter specialists in journalism and public advocacy skills. Why are we doing this as part of public health policy rounds? Because we know that advocacy and health communications is key to policy change. Rob was a communications director for the Ontario COVID-19 Science Advisory Table, so he knows what the heck is going on and not going on. Maybe he can share some secrets. He is a senior public health and healthcare policy advisor to former Prime Minister Paul Martin, and was a senior political advisor to Minister Carolyn Bennett in the creation of the Public Health Agency of Canada, a key player having to do with health crises in this country. He started his career as a foreign correspondent for the Wall Street Journal, was a management consultant at the Boston Consulting Group, and has also served as assistant vice president here at the University of Toronto in charge of strategic communication. So who better than to speak on this topic than Rob Steiner? Following Rob, we are going to have Archon, who's going to speak to us as a discussant for about 5 minutes. He's a fourth-year PhD student in epidemiology, and his research is about waning immunity from the measles vaccine in Ontario. Previously, interestingly, Archon worked as an epidemiologist on global health emergencies, so he's really well placed to speak to this topic as well. He worked for the World Health Organization for 5 years on such topics as Ebola, Zika, and cholera. He has a Master's of Science in Epidemiology from the London School of Hygiene and Tropical Medicine, a BA in Psychology, and a BSc in Microbiology and Immunology from McGill University. So Josh, are we set to go? Perfect, thank you very much. Rob, take it away, more or less 35 minutes.
You guys mind if I take off my mask while I speak? Because I sometimes want to throw on my glasses and I can't see. Is that okay? Everyone? Thank you. Thank you very much, Rob. This is a real honor. Thank you. Well, Josh has left, but thank you, Josh. He's saved my classes a number of times already this year. I assume that we're being joined by a number of people online. So wherever the camera is, hi to all of you. I think actually for full disclosure, my father is one of them, Professor Emeritus in endocrinology here at U of T. And I just want to acknowledge him because he's one of my inspirations for getting into health and kind of getting out of journalism and getting into health over time. And because I also assume that there are a number of public health leaders who may be interested in this stuff and may be joining or watching a little later, and other folks who are heading into those professions, I want to start with two caveats before we get into the whole discussion about what we've learned about communications through the crisis stage of the pandemic. Recognize the pandemic is ongoing. I'm going to refer, maybe I'll slip and casually refer to back during the pandemic. What I mean is during the crisis stage of the pandemic. I don't mean to imply that the pandemic is over. So here are my caveats. The first comes sort of in the form of a bit of a trigger warning. There were a lot of very fraught topics during the crisis stage of the pandemic, ranging from aerosolized versus airborne, IPAC in hospitals, all that kind of stuff. Communications was one of the most fraught topics. And it got very personal. One saw a lot of criticisms, personal criticisms of various public health leaders in Canada and around the world about their communication styles and so on. So I want to say, and I've had that experience working in comms now for about 30 years, that this stuff is personal. It feels personal. It's very intimate in the way that one actually relates to other people. And so my first caveat is to say that while I want to engage in good, robust critique of some of the models we have, this is not and should not be and shouldn't become a criticism of any of the individuals and public health leaders in this country that we're really fortunate to have. During different points in the pandemic, I was arranging interviews for the scientists, but from time to time, I became the subject of the interviews, and my colleagues in the newsrooms were asking me, to comment on the public health communications from public health leaders. And I had to sort of remind them what a public health leader is, right? In this country, first of all, you have to be an MD, which already is a ridiculous level of qualification, right? Like, who gets to be an MD? Then, on top of that, you have to know something about biostats, infectious disease epidemiology, chronic disease epidemiology. You should have a working knowledge of biochem or of cellular biology and microbiology. You, on top of all of the science, and we haven't even scratched the surface on the science stuff, you have to know how policy works. And you also have to know how politics works, and you have to know the politicians. And then on top of all of that, you have to be a manager because you're managing a big unit. And then on top of all of that, you actually have to, run the finances of your thing. And then we expect those people to also be Barack Obama. It's a lot for any individual. And so my hat's off to the people who've done that work. And I hope that if you're joining us, you know that I'm approaching this topic as an ally and as a partner and a colleague, not as a critic. The other thing that I just want to put a caveat on, just before someone sort of raises it in the back and forth that we'll have afterwards, is that in serving on the science table, I and all of us, and there are a couple of us in the room here who were on the science table, we all had the relative luxury of working only on one little piece of this, which was the science. Now, that little piece was massive, right? It covered everything from hematology at some points to vaccinology to epidemiology, et cetera, et cetera, et cetera. But it was just the science. We never had to make public health decisions. We were not in the role of a public health leader, and our co-chairs, Steiner Brown, Brian Schwartz, and our science director, Peter Uni, and later Fahad Razak, continually reminded us that we did not have that hard job. We had a hard enough job, but we didn't have that hard job of actually having to make decisions. So once again, my hat's off to the public health leaders who actually did have to make those decisions, and a recognition of the fact that everything that I say, my entire perspective comes from one little slice of this whole thing. Okay. So having said that, what I want to do in about 30 minutes or so is quickly touch on what we did in how our communications practice at the Ontario Science Table actually ended up, not by design, but just kind of very quickly ended up being inconsistent with the standard models of crisis communications in public health. Second, how that raised some questions about the limits of the standard model of communications, emergency communications in public health. And then third, in the kind of meat of this, is a vision, a new vision for emergency communications, certain types of long-running emergencies in public health, and some work that we're starting to do or trying to get off the ground with the, we'll get off the ground, I'm pretty sure, with the White House Office of Science and Technology Policy on this topic with a pilot in the Southeastern US. So first, science table. Let me just get into this here. Science table, most of you guys know what it was. Basically, I'll touch on it just in 2 sentences. Science table was commissioned by the government to be an independent group of advisors strictly on the science of this unknown pathogen that was suddenly hitting us. It convened in the summer of 2020, so a few months after the beginning of the pandemic. I believe it was the summer of 2020. I came on later. I was a late joiner, not the first time in my life. But very smartly, and I think uniquely in any government advisory table that I've ever come across, it had these really great terms of reference that guaranteed its independence to pursue any scientific question it felt was relevant, A, and B, guaranteed its independence around communications, right? It actually secured for itself, and this is to the credit both of the co-chairs and also, frankly, the government itself that let us do this. The premise was that we would advise the government, and then within a short period of time after advising the government, usually something along the lines of 48 hours, we would share exactly the same, but like exactly the same advice that we presented to the government with the public, without abridgment, without editing, and without asking the government, and without even allowing the government to sort of tell us what we could and couldn't say. So that's pretty unique. Nonetheless, even though they had that communications mandate, I think at the beginning, it wasn't clear that there was actually much of a communications job. I think the thinking was just, we'll throw this stuff up on our website. They didn't have a Twitter feed. We'll just throw it up. It'll be publicly accessible. And quite quickly over time, of course, a combination of fears of growing mistrust, largely out of the United States. We were lucky in Ontario that it wasn't as much of a problem for us. And the fact that the science table itself was increasingly being called on by journalists to COVID, speak about COVID, meant that they actually needed a comms strategy of some sort. And so I began having conversations with them in November of 2020, joined the table in December of 2020, and then served on it for about a year and a half through to the late spring of 2022. All of which is to say there was no plan, there was no manual. In earlier lines of work, I had been trained in emergency communications. I was one of the core emergency team for U of T for 5 years when I ran communications here. And you end up with these big manuals that come out of these emergency simulations. But we didn't have a manual for this. I didn't think of a manual for this. I don't particularly like manuals anyway, because they're very confusing to me. So we just sort of went intuitively. And intuitively, I wasn't even sure for the first little while what my job was. But over time, it became clear to me that the comms mandate for the table was to build trust in the science, then to protect the trust that we were actually building. And because it's a corollary to building and protecting trust, to actually make sure as much as possible that we were communicating consistently with other folks in Ontario and Canada, but particularly in Ontario, who were speaking about COVID, that we were not going out to pick fights. We were not out to be criticizing anyone in public, and that what we were saying was consistent with what Ontarians were hearing elsewhere. And so as the mandate became clearer, our methods also became clearer. One of them was radical transparency, right? This was this idea that what we tell the government, we tell the public. The science doesn't belong to us. It's public science. The data are all from the public. We're drawing on the public for our data. And like any good scientists or academicians, we share what we find, right? It's not confidential. And that we do it quickly and that we do it fully and wholly. That meant sort of a second item here, which was rapid response to media. And that also, as a consequence of this, we would speak with as much nuance in public as we did among ourselves as scientists. I should say, by the way, I'm not a scientist. I'm not a clinician. I'm not a physician. I'm none of that. But I'll speak collectively on behalf of the table. That as scientists, we would speak with nuance. These data show this, but not quite that, or I'm not sure. We have to investigate that. And that we would speak with the public in the same way. That was kind of our method. But increasingly, it became clear to me, because I kind of paid attention to this stuff, that these methods were at odds with the standard emergency communications model that comes out of the CDC in the States, and that is kind of widely adopted as a basic communications model. So here we were being transparent quickly about everything, including nuance, right? The CERC, I always forget what it stands for, but the Crisis and Emergency Risk Communications Model, which is the basic model that comes out of the CDC, has as its premise, they have kind of like 6 things on a wallet card, but the 3 top things on that wallet card are these: be first, be right, be credible. Sounds obvious, sounds simple. Be first, be right, be credible. And you can picture the situation in which that's designed to serve. Imagine the earthquake, the hurricane. Imagine the outbreak of a known pathogen, dengue fever, something of that nature, where you know what the threat is. The threat is affecting an acute population that, for the purposes of that threat, is largely homogeneous. Doesn't mean they're all homogeneous, but they've all experienced the same thing, or they're all at a similar risk. All that kind of stuff, right? You can picture what this is. This is the public health leader standing at the microphone somewhere in Florida, with the sheriff and the governor and the mayor and all those people behind them standing like this, and the public health leader in their rain jacket sort of giving you what's what, and then coming back and doing the next briefing an hour later, right? That's the model. But when you're dealing with something like what we were dealing with, the question is, first of all, what does right mean? And is it credible to claim to be right, right? So, right? So, we're dealing with a pathogen that didn't exist before, that it took us months to even begin to figure out at an elementary level of microbiology. took us, and we still don't entirely understand the dynamics of how it spreads. We certainly, I think science has moved a lot, but we don't have a great understanding of the pathophysiology of this. We're still figuring that out. So when you stand up and you claim to be right, we're all likely to shake our heads a little bit, right? Does that mean you're credible? Well, actually, these things might be at odds in a situation like this. And the other thing is being first. If you're first, it means that you're pushing someone else out of the way, that they shouldn't be first. Now, again, if you're talking about dengue fever or, an outbreak of listeriosis or something like that, okay, that makes a ton of sense, right? There's no one else who's going to be an expert more than the public health person on that particular pathogen. But if you're talking about something that starts to get into education policy, right? Or it starts to get into economic policy or civil rights, what business does the public health scientist or leader have being first? There are other people who have constitutional mandates to speak to that, who have more legitimacy to speak to that. So even that becomes a contradiction. I realized we were, by embracing our uncertainty and the limits of what we could talk about, given that we were just a science table and the science wasn't clear, we were already coming into conflict with the basic methodology. And it started to seem to me that it was possible that this methodology was designed for very limited use. Important for very limited use, but designed for limited use, right? Acute, well understood, limited emergencies. The public health equivalent of a heart attack or a stroke going into the emerge. Or my son, who might also be joining us, by the way, I don't know if you are, hi. He wants to go to med school, so any advice is welcome. My son served in the Coast Guard this summer. When you're in the Coast Guard, you have a coxswain, you have a chief in your boat who's actually in charge of telling you what you're going to do. And you can all interact with your chief, but they're in charge of telling you what you want to do. Okay, so when you're in the emergency room, you don't want to have a lot of public consultation about how you're going to address an infarct or a heart attack or a stroke. You do it, one person's in charge and you go. But in other situations, it's more like diabetes or cancer over the long term, right? Things that affect a heterogeneous population, things that are novel, that are poorly understood, things that are enduring or chronic, things that go over different regions that have different epidemiological characteristics. Those kinds of crises may not be appropriate for the kind of command and control system that goes with be right, be first, be credible, be first, be right, be credible. In fact, as you look at them, the continued application of that command and control system can actually, it seemed to me in lifetime watching this, can actually undermine trust. So if you think of it, right, and I'm looking forward, I hope to having good conversation with any public health leaders who are joining us for rounds this afternoon. But if you look at it, it starts with some tension, right? This command and control system over time, in the first month, 3 weeks, whatever it may be, fine. I'm happy to listen. Tell me what I need to do. But over time, it starts to feel arbitrary, it starts to feel controlling, it starts to feel patronizing, and it may also start to feel irrelevant. And it starts with a certain kind of tension. I remember back in those days, that first spring when all of us were going for like incredibly long walks, and my buddy would say, damn, it looks like a participation ad. And we were kind of both overweight and trying to get fit. Here's a guy who is one of the most educated, smartest people I know. He has degrees from Oxford, U of T, McGill, and the University of Paris. He was a clerk for the Supreme Court. The only thing is that he's a litigator. He's not a scientist. And he was trying to figure out in sort of May of 2020 whether his kids were going to be able to go to camp. And we were out for a walk in Winston Churchill Park, and he sort of just turns to me at one point. He says, why do these folks speak to us as if we're idiots, right? And yes, he was incredibly educated, but the same would be true for someone who didn't go to Oxford, right? Why are they, and I'm not, again, this is not a personal thing about anyone. This comes out of the command and control model. It's almost inevitable. Well, you can see what that provokes, right? That provokes resistance, cynicism, polarization, rejection. All of that becomes a fertile ground for misinformation. You're telling me what to do? Okay, maybe. Think of us all with our parents at a certain age. Okay, maybe, or maybe I'll find out something else. And then when that disjunction begins to happen, when the public starts to distrust public health leadership starts to distrust the public, right? So for those of you who are clinicians, right, this is the situation that arises when the doc sits and says, oh man, I have this patient. I can see his heart attack. I can see it. I know it. And you know what? He keeps partying. He keeps drinking. He keeps eating steak and he doesn't take his meds. I'm done with this guy. Like, what does he think he's doing? Right? He's wasting all of that kind of dissociation and distrust. And I would hear that on the sidelines speaking with my colleagues in public health. You know, the best thing that I could do is to tell them once again, you've got to pay attention. You've got to wear a mask. You've got to stay home. You've got to blah, 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 blah. So it's the public health leader who's now distrusting the public, and it cycles and it accelerates itself. And sure enough, if you are in an environment that has a low level of social trust to begin with, i.e. a lot of parts of the United States, thankfully much less so in Ontario, you progress from tension in the light blue all the way out to distrust. And in August of 2021, a Gallup poll showed that for the first time, the CDC had crossed that line to a point where I think 45% of Americans were polled distrusted effectively. They said that there was no clear communications plan coming from the CDC, which was sort of a surrogate question for them of trying to measure trust in the CDC. It was the first time that had happened consistently. And so we end up in I haven't seen more recent polling data on the CDC. There must be some out there. I haven't come across it. I was looking for it. But that then prompts this question as we leave the crisis phase of COVID, at least for the moment. And this question came out of the White House, out of their Office of Science and Technology Policy. How do we actually rebuild public trust in public health? And this is a project that I'm starting to work on with a colleague at Stanford, Dr. Seema Yasmin. We'll get into that in a second, but it's first worth going back into kind of first principles here, right? What are the characteristics of trust? There is, and I know my colleague Jennifer, we have a bioethicist here who I know has looked philosophically at these kinds of questions. There are vast literatures, plural, on this question of trust, from the philosophy literature, the economics literature, management, sociology, anthropology, et cetera. Bioethics, I'm sure. And I'm not a great, I haven't read all of that literature, to be clear. I've scanned some of it. And what strikes me is that most of these papers in these different fields start by saying, we really don't have an accepted definition of what trust is or what the premises of trust are, but here's a shot. And so I'll give you a shot that comes from a couple of sources. One is from the management literature. One, I think, pretty well accepted premise that emerges in the management literature is that trust is actually connected to vulnerability. I am prepared to be vulnerable to you. Right? I am exposing a vulnerability to you, and I trust that you will not exploit it. I trust that you will use your knowledge of my vulnerability to do something that helps me, and that there's a mutual relationship that's built on vulnerability. But the other dimension that I would add to this is reciprocity. And one of my sort of philosophical heroes, I'm Jewish, and I sort of take that stuff seriously in my own life. One of the great modern Jewish thinkers recently passed away, Rabbi Lord Jonathan Sachs, noted the importance of reciprocity, that reciprocity meant that people were actually on the same team and is a fundamental, recognize that they're on the same team and is a fundamental premise for trust. That you can't have trust if it's not reciprocal. And you know that intuitively. If I'm bearing my soul to you, but you're not doing anything for me in return, or you're not showing yourself equally vulnerable to me, I may have a professional clinical relationship with you. That's why we have therapists. But even there, it's strictly defined. I may trust you to serve me, but it's not a trusting back and forth friendship, right? We know what trust feels like and looks like. And then because some of the other qualities are intuitive, I just sort of thought of some myself and then threw them to a bunch of second-year Masters of Environmental Health students that I was teaching last week. And we were on the same page. So with that really, robust statistical method, I will throw these other ones out there. But I think that it's pretty intuitive to us, right? Trust also involves reliability. You'll be there when I need you. Repeated responsiveness, right? I'm calling you, you're answering, and respect, right? So that's all pretty obvious. And I think we can try to suspend our disbelief a little bit and say, okay, yeah, but that's interpersonal trust, trust in institutions, trust in leaders, trust in political systems. That's a different game. I don't think so. I've worked in politics for a long time. And I think that we look at our leaders as human beings, and that our mechanisms as human beings for building or accepting or having trust in our leaders is very much the same as the mechanisms that we have and the tools that we have for having trust in our friends and the people in our lives. So there are a couple of things that come out of this to me. One, Trust is actually premised on reciprocal vulnerability and responsiveness. Okay? I'm vulnerable to you, you're vulnerable to me. I'm showing you my limits, you're showing me yours, right? And you're going to be there. And if you're there, I'm there. But if you're not there, I'm not going to be there. Over time, this actually is inconsistent with command and control. In command and control, in a command and control method, I'm standing here. I'm not going to show you any vulnerability because we know what we have to do. I'm giving the orders, you're following, right? There's nothing reciprocal about that. Even in a therapeutic relationship where the therapist or the physician may not expose their own vulnerabilities to the patient, that's not how they speak anymore. We'll get into that in a second. And responsiveness, right? That's not a responsive kind of thing. Now, these little wallet cards that you get from the CDC make a big deal of empathy, but empathy doesn't come from a wallet card, and empathy is not performative. Empathy is something that you actually develop by being able to place yourself in someone else's shoes, and that means actually understanding the shoes that someone, not something that you know. We share our concern for all people who are suffering at this time. You know, that's not empathy, right? But you hear those kinds of lines. So it struck me that the premise, the philosophical, the psychological, the emotional premise of trust is inconsistent with the extended use of a command and control mechanism for communications. But clinical health figured that out 40 years ago, right? So I don't know if there are any clinicians here, nurses, physicians, OTs, or in the crowd. Any? Okay, oh, yeah, okay, excellent. I'm just curious, what are you? A pharmacist, okay, sorry, I meant to say pharmacist too, so thank you. There's a whole range of clinical professions, right? And in fact, you guys with your scope of practice extensions are now becoming real primary, like even more in the world of primary care. So, you know, the clinical disciplines figure this out. Patient-centered care was a revolution in clinical care, particularly for physicians 40 years ago. And the idea of patient-centered care, and you may have seen schemas like this, you know, I should put this on the full screen. So you guys can... That's okay. These are the values of patient-centered care, but in a nutshell, and we've all been patients, or we've all accompanied someone to an appointment. I was doing that actually this morning with a family member. And the premise of patient-centered care is that you, as the patient or the patient's family member and / both, are actually a participant, a partner in your care. I am an advisor, maybe not just an advisor, maybe more than that as a clinician. I'm knowledgeable about this, but I don't know your life. And I don't know how we're actually going to apply what I'm saying to you from the therapeutic guidelines and from the science and the diagnosis. I don't know how that's actually going to apply into your life, right? So there's a whole bunch of skills that physicians and other clinicians are now trained to actually incorporate the patient and the patient's family into clinical care without compromising the quality of the care itself. Right? This is very different than the old style of the Herr, Frau, doctor, professor, you know, where you would sit, the doctor would come in, tell you what you needed to do, and then walk out. You know, the stuff of movies. But this is how medicine is practiced today. And this morning, when I accompanied a family member to imaging, this is how that clinician, that radiologist practiced it. Turned to me and said, do you have any questions? Everything clear. What do you want to talk about? They're clearly pressed for time, right? Massive wait list at that particular hospital. But they took the time and they felt that a full briefing to us was right. We just expect that now. Well, it turns out, right, and the philosophy here is that we have to move from what's the matter with our patients to what matters to our patients, right? And that comes from, of all things, an orthopod, which my experience with orthopods does not lend itself to this. So I'm glad that this actually comes from an orthopod. Well, we have not done that. Sorry, I don't know if this is, oh, shoot. I'm going to get rid of that and go back to the full thing. We have not made the same shift really in public health. We have not really moved from what's the matter with our publics to what matters to our publics, right? What's the matter with our patient to what matters to our patient. And there are three elements of patient-centered care that I think are particularly valuable for us in public health if we actually want to build a model of communications, even in emergencies and those extended chronic kind of emergencies that are characteristic now of COVID. and that are different than, the earthquake or the outbreak of dengue fever or something. There are three qualities here. One is full transparency and fast delivery of information. You see that here. And these are the three that I want to talk about a little bit more in depth. The second is that we in public health, and we in public health can do that, and I think we're often tempted not to do that, to not be fully transparent and to not be fast. The second is in the clinical setting, patient and family viewpoints are respected and valued, right? Note that there's no sort of qualification for this. The physician doesn't say, I'll respect your opinion as a patient if you have a science degree. I'll respect your opinion as a patient if you believe in vaccines. There's no question. If you're in the ICU, first of all, there's a sign in the ICU. If you guys, and I hope that no one ever has to go into an ICU as a family member, but I've been, and there's a sign there that says, you are a family member. We want you to be here. Here is the role you play as part of the healthcare team. And when they round, the attending invites, in my case, didn't know that I worked in public health, didn't know I was at the university, just knew that I was my dad's son, invited me into the circle with the residents, the clerks, and the nurses. And they went around and then they came to me, right? So patient and family viewpoints are respected and valued, even if they might seem a little crazy. And third is that the public, like the patient, is welcome in the healthcare setting. This one in a hospital is so obvious now that when they took away visitation rights during the period of the pandemic for all sorts of the right reasons, right? You had to. There was a revolt by a lot of people. How can I not go with my dad or my wife to a screening, much less post-op? This is absolutely de rigueur in the clinic. And we can do it in public health as well. There's a method that I'm going to suggest. So I think that these are kinds of the elements that we can bring to it. I want to go through them kind of quickly. And this is the heart of the work that we propose to the White House. How am I doing for time off? Is this okay?
You're fine.
Okay, good. The first, and this comes out of work that this is the only one of the three elements that I'm suggesting here that we actually did do on the science table. The other two are kind of wish lists, things I wish we'd been able to do at the science table. But this one we did do, which is a radical transparency of scientific and public health logic. This sounds obvious, right? That we actually, when we advised the government on something, we gave the same presentation to the public within 48 hours. We showed them the same data. We built a social media account, a Twitter account, and then we used that to spell the stuff out, not just to post the latest modeling presentation, the latest science brief, but to break it into like a 14-part thread that went through the key points and then linked to the relevant slides. I had some technical problems figuring out how to do that because I'm not really cool, but anyway, we linked to some part of the presentation and people seem to find their own way. We told reporters 24 hours before when it would be coming, where they could find it. We also organized our science table so that anytime we were releasing data or modeling or a science brief on a particular topic, we had a roster of 4 or 5 on a good day, scientists who are authoritative because they've been involved in that modeling or in that data generation, and they could speak to it. We had them lined up ready to actually take calls so that I could actually tell reporters, when you call us, you will get someone who's actually an author of this thing back within the hour, and tell us if an hour is too long because sometimes you have something live where you need to go. Fortunately, sadly, I don't know what you want to say, Peter Uni ended up grabbing most of this stuff, our science director. I say fortunately because he was awesome at it. Sadly, because I think it was probably too much for him. But that's where this came from, this fundamental belief that we needed to be radically transparent. And specifically transparent about the logic, right? When we were saying that Astra, for instance, if you guys remember back to that moment when Astra seemed to have these very dangerous adverse reactions, right? These blood clots, HIT or VIT at the time we were calling it. That we had a particular view on that, that this should be pulled, even though we suggested that it should be used a month earlier, it should be pulled now. We were exhaustive about the logic. Here's why. Here's why if you had it, you don't have to really worry, but here's what you look for. But if you haven't had it yet, don't rush out to get it. In fact, we probably shouldn't be giving it to you. And here's why. so you're taking through, which is very different than an arbitrary announcement, which came from other orders of government, which is just, we will not be distributing this anymore. And left my brother, who is in British Columbia, wondering, I just took this thing. What the hell? Like, I agonized for 3 months over whether I should take it or not. And then I took it. And now you're telling me I shouldn't. And there was no logic behind it. So we were exhausted about this. But it is not how a normal public health unit works, right? The normal way that any government operation works, if you worked in government, the normal way any government operation works is we have a PR line. So we have a communications specialist. They will take all your questions. They will then try to identify the right person within the organization who can answer the questions. They will go and gather the answer to that question. They will respond to you within 2 days, maybe faster if you desperately need it. You will communicate mostly with that person, not directly with the scientist, because trust the scientist to tell you to really stay on message. And then when we go and we do put a scientist in front of you, we're going to prep them really, really well. We're going to have Q's and A's. We're going to script them. This seems ridiculous to me. Could you imagine if you were in a hospital and you were getting cancer care and you had a question about your cancer care? It's inappropriate for you to think that your physician is going to be answering you at your beck and call. No, they're busy. They have other things. But if the response is, please submit it to cancer care questions at Princess Margaret Hospital, we will have the chief of the department respond to you within 2 days, who's not necessarily your clinician, we'd be livid. And it certainly wouldn't build trust. So this kind of radical transparency was important. The one last thing I'll say on this is it's not just against, it's not just inconsistent with the way most government operations operate. It's also inconsistent, frankly, with the way that a lot of scientists think when they think about science. There were a number of times when I was on the call, there was one point when I was like exhausted and totally conked out. And frankly, I turned the camera off and I was sleeping through the science table call, but vaguely listening on the side as they were going on about, and I could follow and understand, but kind of barely. And they were going on about something that was very sciencey. And then there was a pause and they said, yeah, but how do we speak about this with the public? And I was like, oh, unmute, try to get my hair okay, turn on the camera and say, sorry, knowing exactly what you were talking about. The way you speak about it with the public is exactly what you just did here. This was a nuanced conversation. It was thorough. People will get it. And if they don't, they'll ask a question and then you fill it out for them, right? Most scientists are hesitant to speak openly about the nuance of their science, but they're not that hesitant if they happen to be clinicians to do the same with their patients. So we can do this, and I could chat more about this, but it requires a mind shift, and it also requires a system so that no one is getting particularly overwhelmed. Two more elements here, right? So going back here to patient and family viewpoints are respected and valued. Okay. It is easy, you can imagine, right? If you're a physician, a pharmacist, a nurse, an OT, dealing with something complex, to get that patient, maybe their family around and explain these three drugs interact in this way. You're going to have to make sure you take this in the morning, this in the afternoon, you don't do blah, 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 or disease, diabetes management, whatever it may be, right? You get the family in the room, you have the hard conversations, they're difficult to have, and the family helps shape the decision with you. But when it comes to public health, how do you actually get the public in the room, right? You cannot, and I would really recommend against the idea of polling people on what we should do. And that is not what I'm talking about. But we do have issues and like some core dimensions, I'll get to this in a second, core dimensions of public health decision-making that really require a rigorous understanding of where the public is. So we all believe, I think, in the precautionary principle. I assume like everyone knows what the precautionary principle is. Okay, so we all believe, so the precautionary principle in public health basically says, and you'll correct me where I'm getting this wrong. I think I've read my rules, but precautionary principle basically says, if there's a chance that something is going to go wrong, you will operate from the base. It basically says you don't have to wait to know everything in order to make a decision. If you look at the data that you have, as crappy and as opaque as it is, and if it leads you to a sense that this is maybe more dangerous than it isn't, you can make a decision based on that, right? That's the precautionary principle. And it was really reinforced during SARS-1, and Ontario really learned this lesson. And I would actually argue, although I would never argue against precautionary principle, particularly because I have 5 years to tenure, so I'll never argue against the precautionary principle. I would say that we have become a little too ideological and religious about it. because there's another concept that's embedded into the precautionary principle, which is that there's a point of diminishing marginal returns here. When our precaution about everything starts to bump up against the fact that there's going to be resistance, and that maybe the opposition to it, or maybe the inability to get the message out, or the distractions that you have to take, that you have to make in order to deliver policy on the precautionary principle are too great for the public health benefit at the margin. Theoretically, I think we get that. But in order to know where that point of diminishing marginal return is, you need two kinds of data. One kind of data is to get a sense of what the additional public health benefit is of that public health measure. But the other datum that you need is public sentiment. How much is too much? When are we actually pushed too far? When is the reaction going to be stronger than the, when is the, I hate to use this because it's been misused by people inside of a debate that I don't agree with, but when is the medicine worse than the disease? That's a terrible construct. But when is it too much? And we never had that data. We could never, we were guessing, when is it too much to ask Ontarians to do this for the limited marginal return that we were going to get? And the obvious one around all of this was schools. When is it too much? And we were guessing. And I sort of took it on myself to try to guess in a vaguely educated way, but all I had to go on was public polling. And polls are not rigorous enough to be an input to the science. They're not asking, they're not defining the population in a way that is epidemiologically relevant. They're not asking epidemiologically relevant questions. And they're not longitudinal, right? They're very episodic, and so they're not comparable. So how do you get that public viewpoint into the room? So, and that's just one type of question where you need the public viewpoint in the room. Well, it turns out that the South Africans, as in many other dimensions of this pandemic, figured it out. They actually are a great public health environment. They've been through hell, right, with TB and HIV/AIDS, so no surprise, but they're actually really amazing. We know them for their genomic monitoring, but in the course of one of the conversations we were having with colleagues in Gauteng province in South Africa, the area around Joburg, they sort of let slip a piece that was particularly interesting to me, which is that they have these district level listening reports that during the worst periods of their lockdowns, of their crises, when they were really in the midst of trying to ramp up vaccine, once they got it, district level public health officers were asked to fill out forms every week that looked like this. These are so basic, and I'm guessing that they wouldn't take a whole lot of time for a public health officer to fill out. What specific misinformation is happening in your region? This one is from Khayelitsha, which is the large township area outside of Cape Town. There's a very specific thing about the myths that are coming out of Khayelitsha and in the eastern areas around Cape Town. There's a list of the successes they've had. There's a list of things that this public health officer is hearing and that her team is hearing on the ground about reasons to not get vaccinated. It is not in and of itself, the single report is not particularly rigorous, but you put them together with reports that are coming in, and the website is here if you want to check out what it looked like in 2020, 2022 in January of this year. When you put the reports that are coming in from across the country and you have them longitudinally, these are done every week, you actually start to develop a picture. Now in South Africa, when I asked my colleague there how they use these, he said they really made a big difference for public health communications. I think that this was probably too siloed in the public health communication structure in South Africa, and that it probably also should have been a datum for use in public health strategy development, natural public health policy. But in other words, in a pretty simple way, you can get the family in the room from a public health perspective. This is part of what we proposed to the White House for restoration of public health and public trust, or public trust in public health. The last piece is that was patient viewpoints respected and valued. The last piece is the family's welcome in the healthcare setting. Okay, I know I spoke about that a little earlier as a premise. And this is the last element that we brought. And this is actually what we'll probably be piloting in a large metropolitan area in the Southeastern US sometime in the next couple of months, if the funding comes together, which is a dynamic stakeholder system. So the idea here is that there are a whole bunch, when you start dealing with heterogeneous risks, right? There's a landslide, it's pretty homogeneous for that area. Everyone was hit by the landslide, everyone was hit by the tsunami. But when you're talking about infectious disease that is heterogeneous because of different social determinants, different vaccination and immunization, or different vaccinations and immunity rates, or chronic disease, clearly, which is heterogeneous for all those kinds of, not for immunology reasons, but for reasons of social determinants. When you start talking about heterogeneous populations and you have a public health unit that it is not representative, and even if they have people from different communities, is not really representative on the ground of the little subcultures that you might need to get to, like men who have sex with men, but not necessarily out gays dealing with monkeypox, right? The marginalized men who have sex with men who are not part of an organized structure, like little groups that are critical from an epidemiological point of view. How do you get to those folks? If public health units have stakeholder groups at all, my experience is that they're kind of standing static groups with the kinds of usual suspects, the Board of Ed, the Chamber of Commerce, the big companies, that kind of thing, right? But they're not designed epidemiologically to be specific for the needs of a specific public health threat. Okay. And so there's an opportunity here to create what I would call dynamic stakeholder groups. They're dynamic in two ways. Dynamic, first of all, because you set it up in response to the specific scientific needs of a specific public health threat. So it's science-led. The EPIs around the table say, I'm concerned about this population. I'm not talking about everyone who lives north of the 401 or everyone who lives in Peel. I'm talking about these people. That's the group that I'm really concerned about, people who work in warehouses, you know, and have to take public transit to work. I'm very concerned about those folks, right? That's the group. That may or may not be captured by, you know, the Citizens Council of Brampton or something like that. A. And B, it's called into place in response to that specific threat and can ramp up or ramp down its participation and its action in line with that threat. So as the public health unit changes its assessment, we've gone from red now to yellow to green. We go down from meeting every week to meeting every quarter, but we're still meeting because next time we need you guys, you're there. And if we start to go into yellow, we're now going to meet every month, and maybe just hold in your calendars a weekly meeting if we need it. And by the way, what numbers can we get everyone at if you're traveling? And now it's going to red, so we're actually going to be meeting every week, right? So I think that sorry, I was just distracted for a second. So it's dynamic in that sense, science-led, and dynamic in that it paces alongside the actual public health threat, and it's tailored to the specific public health threat. There were a number of situations where we, on my wish list, we would have had this. One of those situations was, as it became clear that there was a differential risk of COVID to the population, South Asian populations in Brampton and in Peel, right? And we were hesitant to talk openly about that because it wasn't clear whether that would stigmatize those populations or not. Right. And we actually had a lot of South Asians on the table, a lot of people on the table who were connected to South Asian communities in Peel. And we still couldn't figure it out. So actually having a group that was on the ground there who could have told us either don't worry about it, we just need the information, or not from you, from us, or something like that would have been tremendously helpful. The other kind of stakeholder that would have been tremendously helpful would have been bank, industrial, and labor economists who could have helped us help the government figure out what, and advise the government on, for instance, what an essential workplace was. You can imagine a stakeholder group where we have this question, right? This question was, we want to shut down everything other than essential workplaces. What is an essential workplace? Well, the EPI would tell us, we're worried about workplaces that are like this. You know, people are crammed together, they take public transit, they're all working one big shop floor, blah, 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 blah. These are the characteristics of that. Over to you, labor and bank analysts who watch the whole economy, to tell us what industrial settings are characterized by those features and what would happen if we shut them down, and tell us, or tell the government, join with us to tell the government, advise the government on what specific industries should be shut down for what period of time and what the mitigating policies would be on the economic side. That's not us in public health. We couldn't do that. I don't think that ever happened. It did happen in Australia and New York State. So there are a bunch, and this actually is the piece that our pilot site is particularly interested in having us work on. And interestingly, they've asked us to develop dynamic stakeholder systems, both for infectious disease and chronic disease. I hadn't thought of it for chronic disease, but their point was, first of all, trying to do anything on infectious disease, we know this from vaccine research, is always touch and go because you have to get there on time and then have everything in place while the outbreak is still happening. But the other point is that you could do this for chronic disease too. And their great example, as it always is diabetes, right? So I think that that's the whole picture. And now at 1:30, I spoke for way too long. That was more than 40 minutes, my apologies. But that gives you a new sense, a different sense of how we can restore public health and public trust with a tool that operates in addition to command and control. That might look a little bit more like this. Ask, listen, integrate what you've heard into public health decisions, not just communications, and then speak. Okay, so that's it. Over to you guys and my discussing. My apologies for going too long.
Thanks very much. It was worth giving you the extra time.
Oh, thank you.
Appreciate it. I'm just coming to the mic so that the people can hear who are also online. I'm just reminding the audience that we are expecting questions and comments. So be thinking every person should have one at their fingertips. Archon, I'm going to take it right over to you and invite you to come up.
All right. Thank you, Mr. Steiner, for that wonderful presentation. Oh, sorry. Can you hear me now?
Yeah.
Okay. So thank you, Mr. Steiner, for that wonderful presentation. I honestly think that your expertise in journalism and media is very much needed in the field of public health. And I just want to say that I really appreciated the title of your presentation, Restoring Public Trust in Public Health. The word trust emphasizes that there is a relationship between public health and the public that needs to be restored. The reason I bring this up is because I think in my core educational training in epidemiology, when we think about communication, we often think about communication with other academics, but we don't necessarily think about communication with the public. And particularly, I think skills in being able to build a relationship with the public isn't necessarily taught or encouraged, I think. In my personal experience, it was only when I started working in emergency response that I had to kind of learn some of these skills through trial and error. So I think it's really fantastic to have someone like you here to share your knowledge and your reflections with us here today. So I believe what you're advocating for is a paradigm shift in public health and how we have a relationship with the public, moving from a model that's very paternalistic and knows what's best for you to a model that is more public-centered, where there's a relationship and a shared decision-making process. So you highlighted the importance of transparency when there's uncertainty, particularly in times of crisis and when there's a novel threat. This made me think a little bit about the time when I worked on Ebola in Sierra Leone. So in Sierra Leone, I worked on a study that looked at the persistence of the Ebola virus among Ebola survivors. So we followed up survivors over time. And when they cleared the virus out of their bodily fluids, they were discharged from the study. And a common question that we got from participants was, is it possible that the virus is dormant somewhere in my body? And is it possible that the virus could come back? And at the time, science didn't know the answer to this question. And us as a research study team and also the Ministry of Health decided to be transparent about that uncertainty. We told them, unfortunately, science doesn't have the answer to this question, but we're here to support you. These are our contact details. This is the contact details of the Ministry of Health. And if that incident does happen, we're here to support you. And even though participants were, a little bit concerned that, science didn't have the answer, I think they really did trust and respect us for being honest and transparent with them. So moving to more recent times with the COVID-19 pandemic, many experts took to Twitter to communicate directly with the public. So Mr. Steiner, I wonder a little bit, obviously don't have the answer to this, whether the way in which we communicate uncertainty and being transparent with the public matters. I will preface by saying I'm not the most active user on Twitter, and I know Twitter has played a big role in how public health has communicated with the public. And I know that on Twitter, there have been disagreements between public health experts about certain decisions that have been made. And obviously Twitter has a certain tone, let's just say, in how experts kind of communicate with one another. And I've heard in my social networks, people who are outside of public health use these kind of disagreements that are happening in a public forum to say, here's evidence that public health has no idea what they're doing. So my question to you is, do you think whether seeing disagreement between experts in such an unfiltered way on a public forum such as Twitter and social media can actually cause more harm in building trust in public health? And secondly, what's the best way to communicate disagreements with between public health experts to the wider public?
Those are great questions. So I think that's a great question. I think tone is the key thing here, right? Twitter lends itself to ad hominems, personal attacks. If you sat in, again, I just keep going back to the clinical example. If you sat in a hospital and you had, I don't know, two different oncologists, or say an oncologist and an obstetrician, and you were dealing with an obstetrical cancer. And if they were going at it with each other saying, really, you think you know that? God, you're just excuse my language, just an effing, oncologist. You know nothing about women's. Oh, really? You think you know? You'd walk out. You'd be like, I don't trust these people. They're not paying attention to me. They're having some little bun fight over something I don't understand. They don't care. But if you sat down with the two of them and they both respected each other, and they said, look, from an oncological point of view, from a cancer point of view, this is how it's behaving. But I'll tell you, it behaves differently in this setting. So over to my colleague from obstetrics, I should say gynecology, not obstetrics. Over to my colleague from gynecology, who will tell you, a little bit more, and you have some other gynecological issues. So we'll talk about that. You'd sit and say, wow, I'm actually being well served. This is thoughtful. And they're not BSing me. They're not pretending to know. So I think you build trust by showing nuance, and you build trust by showing your uncertainty. But I think the tone is really important. And I think the tone needs to be something like, there are really only one of three possibilities. We don't know and we need to know, so that's why we're exploring. We don't know and we can't find this out because the methods aren't possible, but we can explore for a surrogate. And so that's why we're exploring. Or we don't know and we don't really need to know. It would seem like we need to know, but we don't really need to know in order to do what we need to do. So without knowing that, here's what we can do together, right? So being able to share uncertainty builds trust. Being able to do it respectfully builds trust. And I think if one is engaging on social media, we made the decision that we needed to work on social media, but that we would never answer anyone unless it was like a little happy thing, like congrats. Even that, like congrats or thank you or whatever, we didn't answer. But having a respectful conversation on social media, I think, is appropriate and fine. Yeah.
I had one, but I can. Should I? No, thank you. And personally, that's why I kind of stay out of Twitter. Actually, I just find the tone to be not my cup of tea. Oh, thank you. No. I mean, it was just me. It was our research team. But yeah. And then so my last question to you that I kind of was thinking about when I'm thinking about a relationship, and I guess I'm using more at an individual, how do we take it from the individual level to a more broader systems or population level? So when we're thinking about this relationship between public health and the public, I'm just wondering who's best poised to represent public health? And the reason I ask this question is because when I'm thinking from the point of view of the public, and I think of a relationship with these amorphous institutions like CDC or the Ministry of Health, it's kind of hard to think of building a relationship. And I know maybe you might have a different opinion on this. And I think from the public's perspective, maybe having a relationship with an individual is a lot easier to conceptualize. And so during this pandemic, we saw the public had different relationships with different individuals. We had medical officers at the municipal, provincial, and federal level. We had doctors on the ground in hospitals and epidemiologists working in public health, appearing in the media and on Twitter. We also had daily briefings from elected officials, such as the Prime Minister and the Premier, almost acting as representatives of public health in some manner. And so in some of these cases, some of these individuals kind of rose to the occasion and actually had no intention of being a representative, but ended up filling up that role haphazardly. And so I know in your presentation, you kind of mentioned the importance of preparedness and making sure that these relationships exist before the crisis happens. So my question to you is, who do you think is best positioned to represent public health? Is it one individual or all of these individuals? And secondly, how can the relationship with the public be maintained when public health is no longer a priority in the minds of the public, and especially on the agendas of politicians?
That's again a great question, and clearly from someone who's been in the field too. So the first thing I would say is, like, on that first question of who speaks for public health, I think the real risk here is actually what I've sort of come to think of as epistemological trespassing. That's not my term, that's out there in the literature, but epistemological trespassing basically means I'm an expert in this area, and that gives me the authority to comment on everything, right? So I'm an infectious disease doctor who only sees infections in the hospital. I'm a specialist, maybe a subspecialist, who only gets referrals from primary care. I don't see people in the community. And I'm going to comment now on public health policy because I'm an infectious disease specialist. The worst, by the way, and I had a couple of alumni who played this game, much to my chagrin, are people, this room will understand why it's a problem, people who have masters in clinical epidemiology, who then, because it has the word clinical and epidemiology in it, present themselves as if they know something about infectious disease. I had a couple of those out of my journalism alumni, and I thought, to give them the benefit of the doubt, I would kind of look at what they published. And of course, it was all internal medicine, or chronic care or chronic disease, had nothing to do with infectious disease, but they had the word epidemiologist in there. So in other words, the problem, I think, arises when people are speaking out of their turn. So in the same way, a public health leader can't really comment on ICU capacity other than the actual numbers that they may see, which I now know don't necessarily mean anything because they come from folks who may be gaming the system that way too. So people do, in a sense, need to stick in their lane, right? While also, raising questions for other parts, but they need to stick in their epistemological lane, I think, and because that's where they're credible. And then speak respectfully about the other sides of it. Within strict public health, I think the appropriate person is the public health leader, right? The actual head of the unit, understanding also that elected representatives are elected representatives, and they have an ethical and constitutional legitimacy in a democracy. Remember, for those folks who also do global health, right? We also kind of believe that democracy is a social determinant of health. Well, here we have a democracy, so I think we should treat our democratic leaders with that respect and understand their role. I forget the other part of the question, but.
Oh yeah, so how do we build that relationship before?
Oh yeah, so this actually is where I really love this meeting that I had yesterday with the folks at the pilot site, where they said, why don't we do this with chronic disease? I thought that was a brilliant insight, because having these kinds of stakeholder consultations with chronic disease, first of all, you could start any time, right? You don't have to wait for a crisis. But I actually think that, when you're working with folks who are more vulnerable to chronic diseases, you're probably also working with either similar or adjacent populations to the ones who are more vulnerable to infectious disease. So having an ongoing thing, and you'd be surprised, I was surprised that some really sophisticated public health units do not have standing stakeholder relationships or stakeholder mechanisms like that. I was kind of shocked, actually. So just that at the basis. But I also think it's fine for public health leadership to step into the background, because our lives are not about public health. Our lives are about, I don't know, art, if you're an artist, or cars, if you work in a garage, whatever it is, right? We shouldn't be in the forefront of everything because that's not what life is. Life is something else. So anyway, yeah.
So thank you both. That was really wonderful discussion, remarks and questions. Now's the time to ask everybody who's here, and on Zoom, I'll try to see if I can watch in the chat for any questions. But for people in the room, first of all, and particularly people in the training program in public health policy, your questions, your comments, your anger, your curiosity, yes, please go ahead. So the question for those who maybe didn't hear is about the distrust that may be partially connected with private industry roles in the crisis and in its potential remedies.
Again, great question. Thank you. Sorry, great question. So first of all, I think the first thing I'd want to do is to validate some of the skepticism about private sector. I worked in the private sector. I have my MBA from a big US business school. I believe in the private sector. I was a reporter for the Wall Street Journal. But, I think very clearly, and for all sorts of reasons that we've kind of embedded into capitalism, private companies have a fiduciary responsibility that is not necessarily primarily aligned with the broader public good. It's just not their job. Their job is to take care of their equity, their shareholders, and their employees and their customers, right? Get that. And that leads to natural conflicts of interest. But health systems, and it's not necessarily the public health, although, in a broader sense, it's public health, but it's not necessarily the public health unit. In fact, it's not really a public health unit, but health systems actually mediate that relationship through regulation. And I think that a good, solid regulator who is transparent about the application of their regulations can actually broker that relationship, right? It's difficult to fight against conspiracy theories, like I personally am okay that Bill Gates planted a chip in my arm when I got my first COVID vaccine. I'm fine with that because it means that my Waze thing will get me through traffic faster. Totally cool. But other people don't like that so much. No, but to be more serious about it, it's hard to fight conspiracy theories. But what you can do, and what I think regulation was designed to do, was to say, you don't have to trust Pfizer. We don't trust Pfizer. We asked Pfizer to actually go through these tests, right? 4 stages or 3 stages of clinical trials plus aftermarket surveillance. It has to be rigorous, it has to be logarithmic, blah, 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 blah. The problem, I think, arises, when regulators compromise themselves, which, you have state capture all over the place. It's not just in South Africa, right? The FDA compromised itself with, I never know how to pronounce it, Adalimumab or whatever the Alzheimer's non-drug was. The FAA compromised itself with Boeing. You go on and on. These are US regulators, or they're ineffective, right? And I think, to be honest, and I know we probably have some Health Canada colleagues here, I think on some dimensions, Ottawa has been ineffective and not fast enough on certain dimensions of regulation. But the other big comms problem with the regulator is when they don't actually communicate, right? When they simply say yes or no, and you're not smart enough to understand why the yes or no is just yes or no and trust us, right? Which is kind of what we had with vaccine. And when the recommendations around Astra changed, and when recommendations around Moderna changed, it was arbitrary. I actually tried at one point in the middle of that whole Astra kind of fiasco, and our counterparts who were, advising the immunization advisory body, you guys would know it, I forget, NIA's, right, on immunization, right? And they changed their recommendation, and Public Health Canada came out with different guidance. I tried to find the document where they described it and explained the logic, and it didn't exist. What it was it was embedded in their clinical guidance for the vaccine. And there was like a concordance that you could find in a different part of the website. It took me 40 minutes to do this. And I knew what I was looking for. That said, here, if you want to see changes on this, you'll go to this part of the website in these lines. That's terrible. That's like how legislation has changed. So if they're transparent about not just the yes or the no, but also the why, then I think that gives us a basis for trust of the private sector, because in health, and if the regs are good, because in health, everything is regulated as it should be. But the regulation also needs to be effective and fast enough to be relevant. Otherwise, we get pissed off at the regulator for other reasons.
Thank you. Yeah, yes, Hal. All right. So the question is about the need for interpretation of scientific data for public consumption.
So again, a great question. And, I think we all kind of face this. And there was a point, I think, of the pandemic. I know I had this experience with some family members, again, incredibly educated, science-informed people were not denial, but it was like, let me read this study. I read prospectuses all the time at work. Let me read this study. It's like, I work with scientists who wouldn't know how to read this study. So good luck, right? That's why I was quite specific in saying what we need to be transparent about is the logic, right? Simply throwing data out, even for another scientist. And by the way, like, let's not pretend that scientists, right? My dad's an endocrinologist. I doubt that he could read a vaccine study with the same degree of understanding and context that he reads, a metabolism study, right? He'd know the basic biostats and research methodologies, but beyond that, so that's why we need to be transparent about the logic and not just the data. But that's actually easy. All you have to do is slow down for a sec, right? And you have to have someone on the team in my role who's kind of an idiot who could just sort of say, I don't get this, but I'm a fast learner. Can you explain again, why is this clot different than the other clot exactly? Then it's usually 4 sentences. I'm like, got it. And the thing is that most people involved in clinical science know how to do this anyway, because they work with patients. And if they don't work with patients, they teach. And if they teach undergrads, they know how to do this, right? So it's just slowing down. And it's also having the confidence that if I spell out the logic, people will understand. They don't need university degrees to understand. If I know how to fix a car, honestly, if you can fix a car, if you can fix plumbing, if you can fix electrical, if you can run a farm, if you can run a small business, right? All the things involved in running a hardware store or corner store. If someone takes 5 minutes to explain some basic physiology to you, you'll get it. Most people, right?
Yeah. Thanks for the optimistic answer. Great. We'll take another question from people here in the room. Yeah, go ahead. Till 2 o'clock. 2 o'clock. So just to repeat the question is about, you're repeating often the phrase, I don't know. Does that actually increase mistrust?
So I'll throw a question back to you because I'm curious. So first of all, you work in a pharmacy? Okay, as a pharmacist. Okay. And so the people asking you don't know are nurses, physicians, or family members or patients, or? I got it. Right. Yeah. Right. Yeah. Yeah. So I'm actually curious. I'll ask a question to you. What happens next after you say you don't know? What happens next typically in that conversation? They walk away, or do they ask you more? Right. Right. So I actually think that acknowledging you don't know and explaining why you don't know actually stands to build trust. pretending that you know when you kind of clearly don't, or when you're skating on thin ice, undermines trust. Because I sort of know that if I kick the tires on this answer a little bit, it's all going to be flat. But if you could say, look, we don't know, or at least I don't know, and I don't know because of this, but I'll tell you where another resource might be, or we don't know in pharmacology because of this, but there are folks working on it. You know, that kind of thing. Explaining the I don't know, I think actually builds trust. And I think that over time, I mean, I'm sure you've been working a number of years. My guess is that I'm probably older than most people in this room. You know, I'm 54. Over time, you just become a little more comfortable with that. There's a great story that I once heard. This is from economics, not from science. But I had a colleague, when I was a reporter in Japan for the Wall Street Journal, one of my colleagues was the Treasury Department attaché in the US Embassy. So he was the guy responsible for briefing the ambassador on US finance and economic policy. And the ambassador, who was Walter Mondale, former vice president of the US, who had a great sense of humor, once asked this guy, Matt Goodman, who we were both young at the time, we were sort of in our mid-20s, said, hey, Matt, I know you're really smart. You have all your degrees and everything like that. I'm wondering if you could tell me at our next meeting, what is the Treasury's view of where the yen is going to be in, you know, by the end of the year? Matt went off and he was sweating. It's like, oh my God, I have to present to the ambassador. He's a former vice president. He did all of the analysis, called a bunch of people, came back with the whole thing, came back to the next meeting. The next meeting, he sits down and the ambassador says, Matt, I'll have you come up and give us your yen presentation in a second, but I should just tell you that I've just spoken with the Deputy Treasury Secretary, Lawrence Summers, former president of Harvard, you know, basically Nobel Prize, like top economist. I've just spoken with him, asked him the same question. Over to you. And Matt was like, you spoke to my boss's 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 boss, who basically has a Nobel Prize, and you're not telling me what he said? Okay, over to you. So Matt gives his long answer, blah, blah, blah. And we believe the yen is going to be around 120 plus or minus 10 cents by the end of the year. How did I do, Ambassador? And the ambassador says, well, you know, when I spoke to Larry about it this morning, he said he didn't know. He said Treasury Department really has no idea. Could go up, could go down, right? So you trust him because he's Larry Summers, but also because, you know, if you ask the next question, well, what don't you know what factors are behind that? He'll be able to spell it out for you. So I think saying, I don't know, but in a way that shows the logic, actually embeds it in logic, probably helps and builds trust. Yeah.
Great. Thank you. I just want to go to a couple of questions that are in the chat from the Zoom, so you can see it up on the screen. Timothy Coombs, who is an expert in crisis communications, has focused a great deal on the pre-existing relationship with the public to post-crisis outcomes, i.e. to effectively manage a crisis. The organization must have a positive, trusting, and two-way symmetrical relationship with its public. It's a long comment. In your mind, how did the pre-existing relationship between public health and its publics impact our ability to effectively communicate? In one sentence or less.
Very quickly, I don't think there was really much of a relationship with the public health system. In the US, the CDC had a lot of really cool movies made about it. And I think that like Outbreak and stuff, and that all looked cool. So I think there was a brand there, and like, of course, they're on our side. And I think at the beginning that helped. I think that meant that we paid attention and we listened. I think over time, there's a basic level of pre-existing trust in our system that helped, but I don't know that there was a pre-existing relationship.
Are there any more questions in the room? Oh, yes. Radical transparency. Sorry. Thank you for your presentation reflecting on the model dynamic stakeholder systems. In reflecting on our pandemic response, many of our frontline staff, who in non-emergency times work very closely with those unique populations in a variety of ways in assessing community health and planning public health interventions at the local level, were redeployed to roles related to case and contact management, outbreak support, and put on hold the relationship with these local groups and populations. I wonder if protecting some frontline staff in these roles during crisis periods to connect with these groups would be a way to achieve dynamic stakeholder engagement over the long term.
That is a really smart idea. I don't work in a public health unit, so I hadn't put two and two together. Of course, I know that everyone was deployed into the fire. That would seem to make a lot of sense, but I would also never second guess what a public health unit had to do under those first circumstances, particularly when the disease was small enough that we could actually do meaningful case tracing, which obviously it outgrew after a while. But that's a very smart idea. And actually, if you don't mind, I'm going to embed that as a question when I speak with our pilot site.
Great. So I'm just got a couple of thoughts and maybe questions of my own. One is like just generally, how do we fit this into what we learn about public health policy? What is communication and health communication in crisis have to do with public health policy? Well, partially it's that you make a lot of COVID policies. Okay, so these immunizations you should get, you must get, you should mask, you must isolate, etc. But if the communications isn't good, then the implementation is going to be a huge problem. So this has a lot to do with the implementation side of policy. So stay tuned to learn more about that. What I wonder about this whole area is it a damned if you do and damned if you don't situation, right? So you say being transparent, saying, I don't know, it's nuanced, it's complicated, here's the complications. There's so much that we don't know still, and that we certainly didn't know about COVID, that it's the public not in a situation like that going to say, well, okay, they don't know, so I'm going to do what I think, right? So that's just to counter your argument a little bit. Is that the situation? Rather than the other, not telling them everything and basically saying, okay, right now, we don't think you need masks. And then coming back and saying, okay, now's the time for masks. What's better? I mean, it seems to me in both cases, you're screwed. Excuse me.
Okay, thanks, everyone. No, I mean, I think that these kinds of conundra, really well put. I mean, these confront us on all sorts of dimensions of public health and healthcare. What I would say, last couple of things by way of sort of saying thank you and goodbye for the moment. Two things. One is that when we say we don't know, it shouldn't be like a dismissive, and I know that this is not what you meant, but sometimes it comes off this way from public health leaders and from our doctors and from others, a dismissive, I don't know, you're on your own. I don't know, don't ask me. That's not what it is, right? The I don't know is we don't know yet, but here's how we're going to manage, right? And here's what we're looking for. And for the moment, based on the best of our knowledge, based on this, I'm spelling out the logic for you. I'm treating you like a partner in your own care. This is what we would really urge you to do based on this logic, right? So I think that that's how I don't know sounds. It's not, I don't know. It's not that. The second thing is that one of the philosophical bases of patient-centered care is the assumption, the belief, not always warranted to be sure, but that more often than not, patients give a damn about their own health and are smart enough to be engaged in their own health when shown, what the whole context for their health situation is. And I think that we can and should, and I think the evidence really suggests, particularly after COVID, that we should be as trusting of our public, certainly in Ontario, as before. If you think of it, we told everyone to stop their business. We told everyone to essentially kind of be poor because they didn't know that they were going to get a big bailout, right? And the only restaurant that I'm aware of that broke it is Adam's Barbecue, a place I'd never heard of before, which doesn't exist anymore. Hats off to us. I actually think that the public has earned our trust as public health leaders to be a partner in their own care and to make judgments when we don't know. Maybe they do know a little better. Maybe they actually do know a little better about how to manage the risk profile that they have. So thank you so much. Yeah. Thank you.